Welcome everybody to the Community Technical Assistance Center of New York. Today's webinar is Underprivileged and Underserved, the impact of poverty on mental health. My name is Lydia Franco. I am a social worker here, both part of CTAC and the McSilver Institute. I'm here with Cara Dean Assail, who is also a social worker, and Yvette Kelly, who is a licensed mental health counselor. And we both work for CTAC as well as the McSilver Institute for Poverty Policy and Research, or all three of us do. And the focus of our Poverty Institute is really to attend to the root causes and consequences of poverty through a variety of different ways. And since all three of us straddle this world of mental health, behavioral health, and work on issues of poverty, we also thought it was particularly important to really take a minute and think about how this does impact our work as providers. No matter what setting you're in, whether you're a clinician, whether you're an advocate, whether you're a care manager or case manager, whether you're an agency executive or director or supervisor, we do think this is an important topic to consider and to think about when we are working with our clients, especially if we're particularly working in poverty-impacted communities, as probably many of us are. Before we move forward, I do want to highlight a couple housekeeping things. One, and I see probably a couple hands kind of raised, everybody is muted right now. So that we have a few hundred folks that are going to come on to the webinar. So everybody is muted. If you want to communicate with us, we ask you use the chat box. The chat box is on your right-hand side. If you don't see it, then there's a little chat icon or a bubble on the upper right that you can click, and that opens up your chat box. So you can type in your questions, your comments, and then just make sure that you choose in the drop-down send to all panelists. That way all of us as presenters and our host, our technical host, can also view your question or comment. We will have an opportunity to ask, for some feedback throughout the webinar from you, and so we hope that you participate in that. We are looking forward to hearing what your questions or comments are, and we will try to also hold a separate Q&A at the end of the webinar. I do want to highlight that, as many of you saw in our announcement, that this webinar is eligible for one social work CE through New York State. That is through a collaboration that we have with the NYU Silver School of Social Work. So there is a nominal $15 processing fee to be able to process that CE. I do want to highlight a couple really important things, though. If you are not logged on under your own name and you would like to get that CE, we won't be able to track your participation. So it's important that you log on to the webinar under your own name. So for example, there's a group of you logged on under one person's name and a few of you want CE, we won't be able to track your participation in attendance, which is a requirement for getting the CE. So please go ahead now and try to log on under your own name. For some reason you have difficulty doing that, please chat in to our host, and she will help troubleshoot that for you. Briefly, and we're going to give you this information again at the end of the webinar. We're going to send you a reminder or a thank you kind of email sometime tomorrow that will also have the link. And this takes you to the NYU Silver School's CE online portal, where you'll be able to kind of register for, if you don't have an account, create an account or log in. You'll be able to choose today's event. You'll have to answer a post test or a knowledge test. And then you'll have to kind of fill out some other additional information, and that'll be able to process your CE certificate relatively quickly or within a few days. So that information, it will be sent again at the end of the webinar and also in the chat box, and will be sent to you again tomorrow. Okay, so I just briefly wanted to go over some of the things that we're going to cover today. We're going to talk really about sort of what is poverty, what are the effects of poverty, but really about the reciprocal relationship between poverty and mental health, and what does that mean for us in our work. And we also are going to spend quite a bit of time really highlighting the role that we as behavioral health providers, no matter what setting we're in, both at an organizational level as well as at an individual service provider level, what we can do to try to attend to these issues, especially if we're working in these poverty-impacted communities. And we're also going to end with a note, a point on resilience and the role that that plays in our work as well. So I'm going to pass this off now to Cara Dean Assail, who will take us through the first part of the presentation.
Hi, everyone. Thank you so much for joining us today. I'm going to start by talking about social determinants of health. So as we know, I'm sure it's no surprise that it turns out that our Health starts in our homes, our schools, our workplaces, our neighborhoods, and our communities. We know that taking care of ourselves by eating well, staying active, getting exercise, not smoking, getting screenings, getting immunizations, and seeing a doctor when we're sick all influence our health. Our health is also determined in part by access to social and economic opportunities, the resources and supports available in our home, neighborhoods, and communities, the quality of our schooling, the workplaces, the cleanliness of our food, our water, our air, and the nature of our social interactions and relationships. And what I think is really important to point out is that our mental health is also affected by these very same determinants. So understanding the relationship of how people experience the place and the impact of place, quote unquote, on health is fundamental, including both social and physical determinants. Poverty impacts all of these areas. I'm trying to get my slide to move. So you can see our illustration here, that poverty impacts all of these areas that may contribute and interact with other risk factors that affect our health and mental health. I want to start by talking about what poverty is. So I'm going to give you an opportunity for you to tell me. Can you chat in the right-hand corner in your chat box? What does it mean to be poor? What does it mean to be poor in your own words? If you can just chat to the right so that we can get a sense of our baseline definition around what poverty is, and then we'll go into who's affected by poverty.
And as a quick reminder on using the chat box, just fill it in that blank space and make sure the drop-down says send to all panelists before you hit send.
Great. So thank you for answering, everyone. They're coming in very quickly. Not making ends meet, not having your basic needs met, not having lack of basic necessities, lack of access to necessary resources, lack of resources. Very good. Thank you so much. To worry about basic needs, decreased opportunities, not knowing where your next meal is coming from, not having enough, including enough of parents' attention. Excellent. It means to be stressed out and downtrodden, not being able to live comfortably, going without. Wonderful. Thank you so much. And I'm just going to, say the same thing that you're saying. So poverty, what does it mean to be poor? So it's about access, right? Having limited access to financial resources, as you all mentioned, including income and wealth, but also having limited access to other kinds of resources, including social resources, powerful networks, human resources, healthcare and education, and material resources, including housing and clean water. But it's also about, it's also about protection. So a lack of protection from environmental hazards. We can think about what has unfortunately recently happened in Michigan, right? A lack of protection from environmental hazards, but also social hazards around violence and the daily hassles of unstable circumstances. So it's about access, but it's a lack of access, but it's also about lack of protection. And this just sets the stage around the systemic issues of poverty. And it's just a little cute cartoon around, and to the poor of the world we say this: remember, we're counting on you to keep us rich. Our systemic inequalities and how the imbalance is quite pervasive. But what's interesting is that we're not often aware of how pervasive it is. So I just want to quickly show this little graph. This was a study done between Harvard Business School and Duke University. And they asked 5,000 Americans what they thought the distribution of wealth is in the United States. And you'll see in this graph, the yellow is the top 20%. We'll just focus on the yellow, and then the dark blue is the bottom 20%. And so what Americans think it is the middle. What they'd like it to be is more equally distributed. And then what it actually is the very top. And you can see how unequal that is. And it really portrays the inequity and the imbalance and the pervasiveness of it. And just to talk a little bit more about poverty, we have to really attend to some of the myths that exist. And some of those myths, one which I'm sure you probably have heard of, is that you're poor because you're lazy or you don't work hard. So we wanted to just put this in so that you can see that if wealth was the inevitable result of hard work and enterprise, every woman in Africa would be a millionaire. And unfortunately, we know this isn't true, that not every woman in Africa is a millionaire. And so that debunking some of these myths around poverty is really important as we move forward with our discussion. I'm going to pass it over to Lydia Franco.
So to give an additional context, too, I think it's also important to look at sort of what the rates are across the country. So these are rates across the U.S., and it also highlights that there are disparities, right, that there is some variation in how poverty is experienced. So this is one breakdown by race, ethnicity, and this highlights, I think, first and foremost, that everybody experiences poverty. So despite whatever race or ethnicity you are, you will have experienced, you may have experienced poverty, but it does also show a sort of disproportionality. So what you see here is that Blacks and Hispanic primarily above others, and then there's that other category that also is oftentimes difficult to define, also highlights that those who are people of color experience more poverty than those who are white or Caucasian. So I think this is just something important. Again, this is national, it's not New York State, but it's important to highlight sort of what the trend is across the country. But I don't want to just talk about race and ethnicity in terms of disparities, it's also by age. And so the majority of people who have who experience poverty are actually children, anywhere between 0 and 18. And then oftentimes we also think about seniors, but as you can see, it's adults 19 to 64 who have slightly more rates of poverty than those that are 65 plus. So that's another sort of area to highlight. So if you're working primarily with low income, primarily people of color, if you're working with children or working with families in some way, I think this is also just important to keep in mind that there is particular sort of vulnerabilities for some of these populations in experience poverty. And it may be particularly important then for you as a provider to be able to kind of think about some of the things we're going to cover today. And, you know, in urban areas, and I know we're from across the state, so there's all types of populations represented on today's webinar, but I just wanted to highlight that in urban areas, 49% of American children live in low-income families, and that disproportionately, again, goes towards families of color. So this is another area. So if you're in an urban area working with families of color, we know that those are also families or clients that are going to be particularly vulnerable to some of these issues we're going to cover today. So this is just sort of setting the context to give you a little bit of background and understanding around what does poverty look like really in our country.
And so when you think about the amount of people who are impacted by poverty, I think the research is clear. Research has shown that people who live in poverty are at increased risk of mental illness as compared to their economically stable peers. And I also think important to note is that what the research underscores is that there's a cost to being poor, and that cost is emotional, mental, and physical health. So when you think about the relationship between mental health and poverty, we know that in a lot of ways the relationship is pretty straightforward, but it's also very complex. What we know is that poverty is toxic for the health and well-being of children, adolescents, and adults alike. But I think special attention needs to be paid to children who are growing and developing under the strain of poverty, because it really has broad implications for how they fare into adulthood. Higher unemployment, food insecurity, inadequate housing, and exposure to violence in poor communities impose a great psychological burden, and we know that much of the increased risk for compromised physical and mental health for those who are impoverished can be traced to the stress of living without one's needs. We also know that the converse is true as well. When people struggle with mental illness, they are at increased risk of becoming and/or staying poor, they have higher health costs, they experience difficulty in getting and retaining work, and if they are fortunate to be employed, then they tend to be less productive at work. They also have the added burden of dealing with the social stigma and isolation that so often accompanies mental illness. So when you think about this relationship, it is definitely a bidirectional relationship in terms of the link between both poverty and mental health.
And one example that we can show around this is looking at food insecurity. And there is a link in the literature around food insecurity increased by 50 to 80% if a mother has moderate to severe depression. So really illustrating that bidirectional relationship. And I just wanted to let you know that we here at the Institute, the Mix Over Institute, are doing some research around food insecurity and looking at caregivers with children and who attend food pantries. And what we have found is that there's a link between attending a food pantry and having not enough food to eat and adverse childhood experiences. So again, illustrating this relationship. So what is clear is that the socioeconomic status shapes a person's exposure to psychosocial, environmental, and behavioral risk factors that directly and indirectly affect mental health. And what the research tells us is that poverty places children at greater risk for a number of things, including physical problems, low birth weight, low nutrition, poor motor skills, cognitive problems, around higher dropout rates in high school, behavioral problems, including engagement in high-risk activities like drug abuse, early sexual activity that leads to early teen pregnancy, and then also social-emotional problems, which include anxiety, difficulty getting along with peers and adults, and low self-esteem. Health problems are more likely to have comorbid features. Health problems in childhood also set the ground for a full range of adult health problems. Poor school success sets the stage for poor job success, family instability, and low involvement in community activities and organizations. Socioeconomic problems in childhood initiate long-standing patterns of psychopathology and troubled social relationships. This is what the research tells us. And I wanted to just spend a few minutes talking about poverty-related stress. So families make up 2/5 of the U.S. homeless population, which increase the risk of trauma exposure and intense anxiety and uncertainty. 83% of our inner-city youth report experiencing one or more traumatic events. 1 out of 10 children under the age of 6 living in a major American city report witnessing a shooting or stabbing, and that's right here in New York as well. So living with persistent poverty is toxic for one's psychological health. And what we know is there have been several studies that have been done around poverty-related stress, that poverty has an indirect effect on child and adolescent functioning through poverty-related stress. So it's not only poverty in and of itself, it's the stress that's constantly associated with poverty. And that children as young as 6 can feel these effects of poverty-related stress. And so what we're really talking about on some level is our brains on stress. And when our brains are stressed out, so that's supposed to be a brain on the left-hand side, when our brains are stressed out, we can't effectively respond, we can't effectively learn, and we can't effectively process. So we need to keep this in mind. And the traumatic context of poverty has pervasive effects that begin to erode functioning and affect outcomes. So for families, the experience of chronic trauma and stress associated with poverty have been associated with decreased parental effectiveness, limited understanding of child development needs, increased use of harsh discipline, and even high incidence of neglect. For adults, the stress has been associated with higher rates of substance use and a variety of mental health challenges. So what we, in the end, want to drive the point home around children and poverty, that really understanding this link between poverty and child and youth mental health is essential, since mental illness is commonly associated with impairment lasting well into adulthood and have high costs to society. So we know you all know this, but we're going to look at how our organizations are affected and the role of that we have as providers. So I have a poll question here, just to think about the role that providers have. Do we as providers have a role in attending to the link between poverty and mental health? And so you can answer A, yes, B, no, C, I don't know, or D, yes, but I don't know how. So please pick an option now, and then we'll review it in a few seconds. Do we as providers have a role in attending to the link between poverty and mental health? So you have 1 more second to fill in your answers. Yes, no, I don't know, or yes, but I don't know how. And let's pull up those results. It looks like most people say yes. And quite a few have said yes, but I don't know how. Okay, wonderful. Thank you so much for participating.
So let's talk about, we're going to spend a few minutes to talk about our role as community mental health providers. And I think what we know about being a community mental health provider is that we tend to serve a large proportion of individuals who can be classified as either the working poor or individuals who live in poverty. And we can also go a step further and say that people living in poverty tend to be among the most marginalized people in the U.S. And so effective approaches aimed at addressing the mental health wellness among those living in poverty will require organizations to rethink their approach and service delivery models. Organizations will need to abandon their more traditional approaches that for a lot of this population have proven ineffective, for strategies that engage families, that incorporate screening for poverty-related risk factors, that develops an appreciation of the multiple systems that affect these clients' lives and provides a unique approach to mental health counseling that addresses a broad range of individualistic and contextual challenges that poor people routinely experience in their lives. And so this is a quote that I'd like us to think about as we consider our role in this process. And again, as behavioral health providers, we have a role in improving service delivery to the underserved and underprivileged. We also have a role in eliminating healthcare disparities and advocating for policies and laws that promote equality and create systematic change. So like this, when a flower doesn't bloom, you fix the environment in which it grows, not the flower. And so what does this mean for our organizations, and how do we begin to think about how we organize ourselves around really improving the situation for those who are more disadvantaged or impoverished in order to achieve the healthcare outcomes that we would like them to. And so oftentimes, we like to frame this in terms of the business case, and the bottom line is really give providers an understanding as to why are these issues and concerns things that we'd like to pay attention to. And we like to frame it from the business case or the bottom line, because a lot of times we are talking to organizational leaders, and we like to speak to them in a language that they understand around how this may impact the bottom line. And so in a time where there's less money from local, state, and federal governments, providers will need to leverage efficiencies in order to maintain their bottom line. And so being able to attract and provide services to a historically underserved population can translate to additional revenue. Right, so being able to provide services to a historically underserved population, again, will translate to potential additional revenue, because these are not folks who are going elsewhere to get served. These are those who are not being served. Next, let's talk about treatment inefficiencies or efficiencies. So leveraging efficiencies also includes treatment. When staff are adequately trained to provide services in a manner that is engaging, relevant, helpful, and culturally sensitive, the likelihood that an individual will make better gains in treatment increases. This is likely to reduce their length of stay, incidences of premature termination, and allow for speedier access to services for other clientele. So the better the agency serves this population, the quicker that they are to benefit from services, to be able to be discharged from the program, and again, creates an opportunity for others to be served in a more efficient way. And so that, again, is helpful to the bottom line. Let's talk about a term we probably all have heard a million times, which is pay for performance. So those who purchase services such as NCOs and regulators increasingly want to buy results and not services. So there's industry movement consistent with aligning payment incentives with accountability processes towards improving the quality of service delivery. And so providers are being asked to demonstrate that their services are effective and lead to improved wellness. So payers will require, if they have not already, that providers give attention to those hard-to-serve individuals, as these are the individuals who are generally driving healthcare costs. And so organizations will need to demonstrate their ability to understand that their services are, that they are providing what they say they can provide. And this is going to be critical to obtaining payment. Next, we're going to talk about avoidable hospitalizations. Hospital admissions that could be potentially prevented with appropriate care during the initial admission or adequate discharge planning, follow-up, or coordination of care is an area of significant focus. The inability to effectively engage individuals with whom you have a pre-existing relationship in order to avoid and or reduce their use of higher-end services will have bigger implications for providers. As payers attempt to become more efficient in managing their dollars, they will expect the same from those they contract with, and providers will be expected to share in the cost of these services. So again, this will have an impact on the provider's bottom line. And so all of these things are speaking to why it would be important for organizations to begin to rethink about how they are serving these really hard-to-serve populations, and really think about how they are really reorganizing themselves to be in a position to tap into a historically underserved group. So let's take a closer look at what that means. So what does that mean from organizations? How can you begin to look at your service delivery and think about it from a perspective of being able to position yourself to provide services to this population? So we say that you have to begin to examine your agency in light of how you might improve the services to this population, and that you need to take a look at some of your current program policies with a fine eye towards how you may be inadvertently limiting access to those who are disadvantaged. You have to remember that most traditional models are more consistent with middle-class values, and that the policies generally mimic this. And so in understanding that, a lot of kind of how we do normal day-to-day business has been really shaped from this fashion. We also have to consider how we are hiring and recruiting staff. Are we employing a diverse group of staff that have some knowledge and experience in working with impoverished communities? How are we recruiting and retaining our staff? And again, what is your noted practice for engaging hard-to-serve populations? What are the expectations that agencies have put forth in terms of being able to serve these populations, being able to engage them and reach out to them when our traditional methods have not worked? And here are just some of the considerations to think about. When you're thinking about your own organizational culture, how are your admission and discharge and no-shows policy structured? Again, you know, how are people able to easily access your service? You know, are they able to access your service either by coming to your organization, or can your service be accessed in the community? What are your no-show policies? A lot of us, you know, who have worked in community organizations, there's a lot of policies around folks who no-show and them getting discharged. But what are your engagement strategies to really reach out to folks who no-show really pretty much the first time instead of letting the no-shows happen? How are your staff trained to address those who arrive late? Are they instructed to tell them that they are unable to be seen for their appointment, or are they instructed to tell them to, you know, sit tight and they will address them as soon as they're able to? How are your staff encouraged to attend to the concrete needs of those who they serve, who are burdened with the daily stress of living without, knowing that that can take on many different forms in terms of them being able to benefit from services? And are your staff trained on addressing their own biases and judgments in the clinical decision-making process around working with families who are disadvantaged, or individuals who are disadvantaged? And here are just some helpful approaches that I would like to consider when you're working with folks who are economically disadvantaged. Again, being able to provide services in the home or in the community, so being able to offer that service to them in a place and time that is suitable for them is also very helpful. Helping them secure transportation, whether it's through family, friends, Medi-Cab, other service providers, that's helpful. Implementing creative strategies that result in the provision of free daycare. So perhaps if you're able to offer that either through maybe an intern or just another individual in the building, that's helpful. And having relationships with some of those concrete services, so like food pantries and shelters, so that when there is an identified need that you have an avenue to really reach out and help that individual. And so one thing that I want to kind of talk about when surveying those who live in poverty is really, I think this is an important piece to consider, is really the difference between this focus, between this present time versus future time orientation, and understanding the impact that poverty has on this. When you are impoverished and there's the constant strain of facing survival challenge, it really results in individuals developing a very strong present time orientation. And that's because they're living day to day, right? So they can't be worried about what's going to happen later because they're focused on what's going to happen now and really getting their needs met in the moment. And in sharp contrast to that is really the future time focus that generally is accompanied from a more privileged economic class. And so in providing services to this population, you have to understand that they are really operating in the present. And so there is some tailoring of an approach that you need to do, because it really is hard for them to think about, for some, to think about, and I use this example in my own work in terms of treatment planning. I'm going to use a clinical example right now, but in terms of treatment planning, most of us from a regulatory standpoint understand that treatment plans are to be done every 90 days. And so if you're working with an individual who lives in poverty and they're thinking on a day-to-day basis, 90 days, they have no idea what they're going to be doing in 90 days. And to be quite frank, they can't even think about the possibilities of what's going to occur in 90 days. And so if you are working with someone who's impoverished, you really want to be thinking less than 90 days, right? You really want to be developing a treatment plan that really is focused on, I'd say as far out, maybe just a few days, and really be working with that individual to tailor that plan, perhaps on a weekly basis versus an every 90-day basis. And so, again, from a regulatory standpoint, you minimally must do a treatment plan every 90 days, but it doesn't preclude you from doing it more often. And so my suggestion is, if you are considering and thinking about what's going to work in the best interest of the person that you're working with, it probably would be in the best interest to really work with them on a very short basis, because that's where they are. And it's their circumstances that really kind of have them there. And so I think that's important when you're thinking about working with the impoverished. It really the focus is right now. With, when you're working with them, the thought is that you can eventually lead them down the road to be thinking more further along, but you really have to start where they are. And so, so that's one of those helpful approaches that I think people should be aware of, is really that focus on they can only be concerned about what's happening in the present, and how sometimes our work with them is a little different and does not necessarily take that into account. And lastly, I think one of the key pieces is that we want to use data to improve access and use of services. We always want to be tracking what we're doing with folks. We also want to identify our target patients in the greatest need. We want to be looking at what are some of the service gaps that we are coming across, and what are some of the trends that we want to address. But we just want to make sure that we have all this data so that we can make informed decisions about our services and how we might be best positioned to provide services to this population.
And so an additional note about data is that data really can be eye-opening in many respects, so that, you can look at are there any disparities in how we serve people, in outcomes, for example. Are there any, whether it's by age or race or language preference or immigrant status or a variety of different reasons? Obviously looking at depths of poverty is another important area. Is there anything, is there any disparity in terms of improvement in outcomes? I mean, have we looked at that data? Who is dropping out? Have we looked at the demographics of who is dropping out of services and why? Who is accessing our services? How clearly do we know and understand those demographics? So really we can use that data that many of us are probably already collecting, we're just maybe not taking a look at it in this way, to really help inform not only a better understanding of who we serve, but how can we better improve our services, really taking into account this issue of access or lack of access to resources, as well as any other type of disparities that our families or our adult clients may be experiencing. So that did, I think, a great job of really highlighting some of those agency-level policies, procedures, different things that we can do organizationally, both as directors, as executives, as clinical supervisors, to help support moving forward in better serving some of the clients that we serve. What I also wanted to highlight, though, is sort of the direct service provider and the role that engagement or that rapport building or that alliance really plays. And when I'm talking about direct service provider, I'm talking about not just clinicians in a therapeutic context, but I'm also talking about case managers and advocates and a variety of different folks that work directly with clients in the mental health field. And what's important also to highlight is that oftentimes those living in poverty either have difficulty accessing services, but when they do access services, they either underutilize or prematurely terminate. So that's sort of our no-show rate. Those are those who don't really use the services the way we'd hope they would, or end services early. So part of that is asking, in terms of direct service provision, what is our role in working with some of our clients? What is our perspective? And I think this is also where we also have to take it not just from an organizational level and our policies and procedures, but for us as providers, what is our own biases that we may be bringing to the table? What is our understanding of poverty? Do we have an understanding of systemic and structural inequities that also impact the reason why we see such disparities? What is our individual bias? Oftentimes, and it's an election year, so you hear a lot of this sometimes in the media, the focus on blaming the poor for being poor. And it's that they can't pick themselves up by their own bootstraps. It's their responsibility, it's their fault, and it's a very individualistic type of focus. But that completely ignores the systemic inequalities that also may exist. So then the question is, what types of messages based on our own beliefs do we bring to the table, although we may not say these things directly, but do we ever communicate in any way? And this is really an opportunity for self-assessment, of which we've all had to do, is do we ever communicate in a way sort of that we believe it's really just, it's their fault? Do we really focus on, well, that's your problem, or you're the one to blame, or you're not doing enough? And so this is an opportunity to also think about not just sort of policies, but how are we interacting with our clients? What are our own values? Could we be really focused on a deficit-based model that then places this excessive blame on our clients? Which then, as a client, if I'm in that position, whether it's said directly or indirectly, I will feel judged. I will feel like, my provider may not understand where I'm coming from or who I am, and then I may be less likely to kind of follow through with recommendations that that person offers, or I may be less likely to participate because I think they just don't get me, or they don't really understand the difficulty of the circumstances that we are in. So it's really also taking an opportunity to think about, how can we do services the same way as Yvette spent some time talking about treatment planning. And, we oftentimes think of treatment plans in a certain way. In the same way that we're talking about, can we change our approach to treatment planning, still within regulatory requirements and meeting all our necessary demands, but can we better serve our clients by thinking a little bit more out of the box in the way we serve? And when we're talking about engagement, alliance, rapport building, whatever name you want to put on it, it's really that opportunity to build that relationship with your client And that first and foremost is, and these are more points here that you can also use as a self-assessment, is are we really communicating a genuine sense of respect for our clients and the circumstances that they are in? Do we try to understand their circumstances? Do we talk about, you know, how difficult it may be to put food on the table? Do we talk about sort of their housing? Do we spend some time talking about the context in which they are living and surviving, as opposed to just going straight to the mental health issue at hand? Do we talk about sort of an understanding and a respect for their ability to build coping strategies and to survive in this complex system and dealing with multiple stressors? Do we give practical and concrete suggestions for dealing with these unique needs? I don't think that got a chance to talk about this at the agency level, but we've worked with some agencies who also, you know, they take the time to ask about, you know, do you have enough food? Do you ever feel like you go without food? Or those types of questions, and that they've taken the time to kind of create their own little emergency food pantry within their agency. So it doesn't have to be a formal food pantry, but, you know, you have a few extra cans of food or things that are, you know, that are not perishable that then you can give to people in immediate need. And sometimes we are working with clients who are in immediate crisis, but they may not share it. We also have worked with agencies who also have their own coat drives. They've done different things to try to attend to some of these issues. Another area, so if I'm going to be asking about some of these things, another area is also to consider our collaborations and our with other agencies that do serve these things. So like, do we have any collaborations with food pantries so we can better communicate and refer people to them? Do we have any relationships with other types of agencies, legal services, advocacy groups, housing advocacy, and a variety of different things so that we can have a better and easier referral process? And also sharing of information, because sometimes what our clients need is just information that they oftentimes don't have access to. So that's another thing. So in building this engagement, in building this alliance, it's communicating and understanding of their circumstances, trying to attend to any of those circumstances if you can in any way possible, but also making sure not to overemphasize an individual client's responsibility for being disadvantaged. That, you know, obviously we all play different roles in this, but that there is a reality of structural inequality that oftentimes go unaddressed. And so as providers, what is our understanding of the barriers that some of our clients may be experiencing, and how can we better adapt services to have a clear understanding of what those are? So this is a great quote. The worst thing about poverty is not the actual living of it, but the shame of it. And I think that that's probably one of the main reasons why this is oftentimes not talked about. So on the client side, you know, I don't want to talk. I'm less likely to talk to you about why I don't have food at the table, or at the end of the month I may not have enough to get by. There's a lot of shame, there's a lot of stigma to that, there's a lot of judgment that then gets placed on the person around that. So oftentimes these are conversations that go undiscussed. I think on a provider level, so I'm thinking in my clinical experience, another area is that oftentimes my clients, they were all low income. So working in Medicaid clinics, you know, obviously they all met a certain threshold to have Medicaid. And so there was also this assumption, well, everybody's in poverty, so what can I do about it? So it became sort of this thing that you kind of know exists, but you kind of forget. So you feel as a provider, oftentimes I can't do anything about it. Oftentimes I feel like, well, this is just the norm. And then we just focus on the mental health issue, but ignore that context oftentimes, because we also either don't know what to do about it, ignore it, or maybe our biases kind of play a role. So I think this is also an opportunity to talk about sort of what that reality is like, even if all our clients are experiencing this, what that reality is like for the clients we serve. It may be a different experience for each one. Some may be in a deeper poverty than others. Some may have better resources than others. So there is some variety, and that's why it's also important to talk about what that experience is like for them. And I wanted to highlight and give you some key questions that you as providers really can take with you. And so there's this great work coming out of Canada, actually. It's also within some of the healthcare systems and some healthcare providers. They're really focusing on, before even going into the reason why you came for a visit, let's do a poverty screen. Because we also know, similar with ACEs, where you know that Certain adverse childhood experiences are connected to certain health issues. So if you find out about certain ACEs early on in your work with your clients, that you're more likely to also keep track of whether those health issues come about. In many respects, poverty is also connected, as we had talked about, to a variety of different mental health and health issues. And so here are some key questions that you can use as a screen. And we oftentimes recommend these not just in the beginning of services, but also periodically throughout, because as we know, the circumstances that our clients live in may vary in the time that we're seeing them. So simple questions like, do you have trouble making ends meet? Do you have trouble feeding your family? Do you have trouble paying for medications? And in our work, there's oftentimes a lot of medications that get prescribed. Is there any issue with that? Is the insurance really covering it? Are we having some of these conversations? Do you have legal or immigration challenges? Do you have a safe and clean place to live? Have you applied for any and all applicable benefits and assistance? And I think this is also where, as we start asking these questions, we also may want to have certain things in place, like those relationships with other providers who can help with legal services, who can help with, in terms of access to food, who can help with a variety of these things, housing advocacy, for example. Can we create those partnerships? Can we have a clear referral list, a resource list, different things like that that we can have readily available to provide for our families? I think we all, in some way, do some of this work. I remember also doing quite a bit of advocacy letters. Unfortunately, to access certain services, oftentimes you need a sort of an authority figure kind of person to write a formal letter on letterhead, even though the clients were rightfully eligible to receive them without that letter, which is oftentimes frustrating. So I oftentimes had to do that, as I'm sure many of you do as well. But one other area that I oftentimes did not do, and Kara had mentioned this quote before, is that I worked with families. So I had a lot of mothers and other caregivers who had depression. And so looking at this quote, I'm thinking, God, probably most of my caseload had parents with their own mental health issues, many of them depression. So I really, when I think back, I oftentimes missed an opportunity to talk about food insecurity that I probably should have, and I wish I had known this at the time, because we never talked about food insecurity. We never talked about lack of access or enough food for the family. And this is something that I think is important for us to know, that as we become more aware of these issues, we're more likely to ask and then be a liaison to help our clients really access those services as much as possible. So I think it's not just about some of the things that we tend to come across, like we may hear more about housing than other issues, but food is one that oftentimes maybe goes undiscussed. So I think it's also important to highlight those. And I wanted to highlight a couple things before we kind of wrap up, because we do want to leave some time for Q&A, is this concept of resilience. So, just because you're poor doesn't mean you aren't resilient, and oftentimes quite the opposite. We're talking about people in survival mode, as Yvette has mentioned. We are working with clients who have figured out a variety of different coping strategies to survive, to kind of have their basic needs met as much as possible. And that oftentimes it's those coping strategies that can be starting points for strengths, that can be starting points for providers to explore and build on when faced with stressors that adversely affect those that we serve. So can we look at some of those coping strategies as strengths and go from there? And sometimes there may be some strategies that we think, this could have been done a little bit differently. So we do come from a stance that we believe that our clients are really doing the best they can with the resources and skills that they have available to them, and it's our job to support them to really help build those skills, whether it's coping skills or other types of skills, and try to be a liaison to access some of these services. So there's an opportunity here. There is a lot of resilience we can work off of in working towards improving mental health in the clients that we work with, and so we wanted to make sure to kind of highlight that important note. So we do have a few minutes for questions, and we've had some that have come in. And I'm going to highlight these resources. So feel free right now to kind of chat in any other questions that you have. So again, use that chat box sent to all panelists. And we just want to highlight that there's a number of resources. These are only a couple that we've highlighted. So one, that there's an interesting calculator at nccp.org that helps to calculate how much families need to have basic necessities. So if you're working with a family and this is something you can do, you may want to explore the use of that calculator. They also had a number of other resources that you can access, and they even are able to get down to a local level. So they've tied sort of costs to local localities, not just, and it's I think a national resource, but they've been able to tie down maybe to state and even maybe metropolitan area as well. So that's one potential resource. Earned income tax credit, taxes are coming up. Tax date is soon. Earned income tax credit is something that oftentimes goes unused, and there's been millions of dollars that families could have had access to that they didn't. So we do actually encourage providers to share this information as much as possible. If you go to our ctacny.com website, you'll see a short video on that you can also share with your family.
There's a lot of research that has shown that the earned income tax credit actually pulls families and people out of poverty for about 6 to 8 months out of the year. So I really recommend you help people go and fill out their information around that and earn income tax credit. Also, I want to mention the poverty simulation game, placespent.org. This is something that you could do in staff meetings. It's really interesting. It shows you, it really helps to get a real understanding, which I'm sure many of you do working with your clients, but it can be fun, especially for new people joining your organization. So we do have a few questions.
So there was a question earlier that asked about the sort of poverty threshold that was used for some of the stats that we had. And so I just want to add, it was a standard poverty threshold stat used by the federal government. And I believe that's typically the poverty threshold for a family of 3 as the basis. And that was about $19,000 at the time that they did the statistics 2 years ago. So I hope that answers that question. We've had a couple others that come in, for example, and maybe I'll refer to Yvette, who is also a director of a mental health clinic, that from her perspective, sorry, just jumped on me.
Yeah, the question was that the clinic, people come in mostly for financial assistance, and and they're doing that more and more, and you'd like them to use other services. It seems. Do you have any suggestions?
Or that if you provide any type of financial assistance, how do you prevent families from becoming solely reliant on them?
Yeah, I think we have to keep in mind that you know, families who are impoverished will seek out services wherever they can get them from. So I think if you offer some financial assistance, it's not unusual for them to come back time and time again requesting assistance. I think that the key, though, is that you don't want to make them dependent on you for that assistance, and so you want to give them other tools and strategies for accessing other resources in the community, other ways that they may be able to get their needs met on a more consistent basis, and give them some of those resources like Kara mentioned. If they're you know, have not filed their taxes, you want to see what you can explore in terms of things, because a lot of times families have not taken advantage of some of those things that they are entitled to. And so you really want to talk with them about earned income credit or some other resources that they may be eligible for. And you really want to help them think about what other community resources they can tap into to really kind of get them thinking about how they may, what's going to be their plan for sustainability long term. So again, not unusual that they keep coming back and asking, but again, you don't want them to be dependent on you. You really want them to have some tools in their tool bags and really, you know, again, tap into some of those other resources that are more approach, that are more, like earned income credit. That they can file for taxes. And I always say, if you have a individual who's arrived in your office and has not filed taxes in the last couple of years, most of the times they don't know that they would have actually gotten a refund for the last 3 years. I'd say help them go back and recapture that income. And that's the way that you can help support them.
Okay, so we have, in the meantime, we've had a couple questions about CE and completion of that. That is up to you and your timeline in terms of how you want to complete that CE. That goes, again, through the NYU Silver School of Social Work, not CTAC. So when you log in, you can follow the instructions, and if you have any difficulty, they have contact information as well to answer if you have any challenges in following through with that process. But it's relatively straightforward. I'm going to remind folks again, because I'm getting that question as well, that the slides will be posted on the www.ctacny.com website within a day. The video recording will also be posted on the website, and so you'll be able to download those slides and resources from there. You'll be able to probably go to clinical trainings and then go to the list of offerings and choose our webinar. Someone asked, can you offer suggestions how to address these issues as if our program can't directly assist but can only refer to other resources? Sometimes people feel like they're passed around.
Yeah, I think just exactly what we were talking about. I think it's important for agencies to really have community partners in providing some of the concrete basic needs. And really, I think having a conversation with individuals who arrive at your office in terms of, you know, we don't provide these services directly, but we partner with these agencies and really helping them understand that. I think if you're clear about who you partner with, if you partner consistently, if you tell them, if you have information about the service, you know, we don't do this service directly, but we know where you can get this service. You can go to the food bank here, this day, this time. If you're more concrete about those details, that they'll feel less like they're being passed around.
Yeah. So others have mentioned that there's some interesting initiatives in New York State. For example, the Rochester Monroe County Poverty Initiative, which we've also been aware of, and we're in talks with some of the folks who are involved in that partnership to see how that's going. So for those who are interested, you can look it up as well. It is an interesting initiative, cross-system approach in that county to attend to issues of poverty in that area. Others have highlighted, just to highlight some comments, that it isn't just about sort of this, you know, our individual work, but it's also this systemic issue, and how do we attend to this systemic issue? And I think that's a question that we all have. I think for us, I think for us as a Poverty Institute, we develop relationships with city and state agencies. We've tried to attend to have collaborations with folks nationally to try to kind of pick at this one by one in a variety of different ways. We obviously are doing some work in our mental health system, but we've also been doing work in housing. We've been doing work around food and food issues. We also, connected to a university, are able to do research that helps to kind of move that bar a little bit as much as possible by trying to better inform the types of needs that people have, as well as ways to attend to them or address them. So we're hoping to be able to do that also with research. And I think it's a big question, it's a big issue. I don't know if we have the answer for that, but it's definitely something that we're trying to attend to, at least through some of our research and policy initiatives. Just trying to see if there's any other remaining questions we can get to before our time is up. And so some said that some of the poverty questions maybe could be reworded in a more positive way, and I think you're absolutely right. So for example, one could be, do you and your family have access to enough food during the month? So I think it's important to talk about access, but it's also important to talk about sort of how they're able to utilize that access. So it's continuing that conversation. But yes, absolutely. Take some of those questions, reword them, really be able to utilize them in a way that you think would be meaningful. And I think our time is about up. There's a number of comments coming in.
So there's a question about a low-cost online tax prep site. I should mention there's resources out there for those who make under a certain threshold. I believe it's $62,000. Don't quote me on that, but it's somewhere around there, where they're able to get their tax prep free. I know TurboTax, if you make under a certain threshold and have to file like just an easy tax form, they do those filings for free online. So you can utilize that as a resource, as most of them do. So again, if you have a family who is in that category, you're looking for some resources for that, I know TurboTax is one of them.
Okay. And so I think there was a comment about whether or not to talk to families about the impact of poverty and it has it on parenting. I think that's a conversation to have. Yeah. I think it's also part of that engagement process. So when you're talking about sort of what are the circumstances that you're living in, how does that impact sort of, if you're talking to a parent, how does that impact you in terms of parenting, then I think that's information that you're gathering, you're trying to better understand context, you're trying to better engage and understand where that parent is coming from. But I think that there are certain realities. So we do a lot of work around kids with behavioral problems, and it's very clear to us that before we start talking about for example, limit setting, then we also have to talk about the realities of, do they have enough food on the table? Because who's going to be able to do limit setting or charting of behaviors or all those other things if they're worried about food? So there is this, like that Maslow's hierarchy of needs. I think it is important for us to consider that, because sometimes when we're asking families to do, or our adult clients or whoever we're working with, it really may be unfeasible. So part of that is having that open conversation about what is realistic, what works for the clients that we serve. So we think absolutely having those conversations are important.
Yeah, and just a reminder before we end the presentation today is just to remember that, you know, as much as possible, if you can sit with your clients and really sit with them and assess what their needs are, and really tap into some things that they perhaps are not, that they're eligible for, but they're not getting, in part because sometimes when you're living in poverty, you don't really have time to focus, or you don't have the energy or frustration tolerance to deal with some of the bureaucratic stuff that happens when you are eligible for a particular benefit. But you really want to help them kind of work through that process, because again, what I find is that sometimes folks are eligible for a lot more than they are actually getting, but they just have not had the stamina to kind of sit through the process, or they've gone but they've walked off, or they've not completed the process, they haven't followed up. And really some of those community resources would be invaluable to them. So a lot of time I've done like an asset check with them, and to really kind of see what they would be eligible for, to see if there's some things in the community that I could assist them in getting. One example of that, and I'm sure that you guys have done this, is like Social Security benefits. Sometimes people are eligible for those. Those take very long time to get, but when they get them, they're very helpful. And so because it's such long-term, again, it's that future focus versus that present time focus, they may not really be resolved to sitting through that process, but I really do kind of sit with them and say, listen, we're just going to get through this, because in the long run, it's going to help you out. So again, helping individuals and families understand that, and really, you know, helping them through those processes really does benefit them in the long run.
And that you as providers and organizations can sit down and take this material and think about, do you want to do something differently moving forward around the population that you serve, is one of our hopes for today. So thank you so much for joining us. We want to talk about upcoming webinars.
So I just wanted to make one note just before we talk about the upcoming webinars. I basically just wanted to point out, and there were some questions around sort of financial assistance or all these other types of things. Sometimes what may be our role is to share information. So share information about the Earned Income Tax Credit, share information about resources, eligibility, things like that. Oftentimes our clients don't have that information available to them in an easily accessible way. And sometimes it's that sharing of information that actually helps some of our clients exponentially if you don't feel that as an agency you can provide more concrete types of resources. So we have two webinars that are coming up, April 15th from 1 to 2, Mental Health Issues in LGBT Populations. And on April 28th, we're going to talk about how racism and discrimination impacts those we serve as well. So we think those are really important webinars. You should receive CTAC email announcements about them, so you'll have the registration link in those emails. Feel free to contact us if you have any questions. Again, you'll receive the information about the Social Work CE in your email by tomorrow. You have time to complete that. There was a question around how quickly do we have to do that. So that is up to you. Once you log in, you can follow their instructions. And they have an email on their website to answer any and troubleshoot any problems that you may have. Thank you, everybody, for participating in today's webinar. We hope you have a wonderful day. And make sure to check out our website, www.ctacny.com, for the slides, the video, and any additional resources. Take care.